Hi everyone, welcome to the Listening Midwife 2026, and we've got a whole new bunch of episodes lined up for you. I'm Day Day, aka the Listening Midwife, and today I've got with me Rachel.
Hello.
Rachel, what do you do?
I'm a diabetes specialist midwife, and I've been doing it for a very long time, as you can tell from the grey hair. And
That's all the ladies has given you the grey hairs, is it?
My specialist subject, which I could talk about all day, so I'm going to try to be as succinct as I can.
Perfect. So ladies, if you've heard about diabetes, if you have diabetes, if you know a friend who's had diabetes in pregnancy, if you aren't pregnant but considering pregnancy and have diabetes, then this is hopefully going to give you all the information you need to be educated and well informed in your pregnancy. If you've had diabetes in a previous pregnancy, it will also help you with preparing for subsequent pregnancies as well. So without further ado, shall we?
Okay, yes, carry on.
So, Rachel, tell us, what are the different types of diabetes that are out there?
Yes, well, I at risk of being very, very complicated, there is a type of diabetes that's pre-existing, so diabetes that you have before you're pregnant. And the main ones of those are type 1 diabetes and type 2 diabetes, both very serious conditions, and a few rare inherited disorders, genetic disorders like MODY and GCK. So we won't be going into those, but just to bear in mind that they're there. And then the vast majority of the women that we see in hospital are diagnosed in pregnancy with gestational diabetes, so diabetes that sits within a pregnancy.
And so let's talk a little bit about the pre-existing diabetes. So my audience is basically women who will become pregnant, are pregnant, or that they're women, so there's a risk of pregnancy at some point.
Yes. Between the ages of 12 and 60, I would say.
That's it, yeah. So it's quite a big window of opportunity, shall we call it. So for women who have pre-existing diabetes, what does that look like in preparation for a pregnancy? What do they need to be aware of? What do they need to know about?
Well, it's the most important thing. It's so important to prepare for a pregnancy if you have pre-existing diabetes. And what we want for the best possible outcomes for both you and that baby in the pregnancy is an HbA1c, so a long-term glucose level of below 48. So the first thing you do is you see your GP, you ask for this blood test, and you see where you are, what that baseline is. If it's below 48, off you go. If it's over 48, take some time to try and modify that level by managing your blood glucose levels, managing your diet and exercise and behaviours to bring that down below 48. If it's a concern that pregnancy is going to take a really long time and you haven't got time to do that, then talk to your GP about what's sort of sensible. But the best possible outcomes of pregnancy are when you have this long-term glucose level of below 48. And it's very difficult sometimes to know. You can't know what your HbA1c is. It's definitely a blood test that you need to have.
Yeah, that blood test looks at the red blood cells, and it looks at sugars that have been attached to the blood cells and how long that process has occurred, and that gives an idea of how well controlled the diabetes is. So that is why it's so important to have that test, especially if you're planning to get pregnant, because then you can go into your pregnancy as healthy as you can be. And some of those modifications. So you mentioned diet. Yes. Is that the main thing that we need to focus on when you're talking about pre-existing diabetes?
Well, it's part of the main thing. So if you have type 1 diabetes, you're not going to secure an HbA1c below 48 with diet alone. You've got to modify your treatments. If you have type 2 diabetes that you manage on diet or oral hypoglycemic like metformin, then you probably can get there with diet. But it's very individual how you're going to achieve that level. And like Dodo said, the HbA1c, because glucose loves to stick to red blood cells, and a red blood cells is active for 3 months, it does give you a really good picture of where your treatment level is. And if it's raised, see your GP, see your practice midwife and practice nurse to sort that out.
Yeah, they're a great source of, support, because that is what they do. It's just like if you were pregnant and you had diabetes, you'd come to Rachel and she'd give you, the tools to help you to have, the best possible outcomes during your pregnancy.
I would start, Dede, as well, because all women, if you're planning a pregnancy, should start folic acid at a higher dose in diabetes. So we talk about 5 milligrams once a day, and you can only get this on prescription. So please start that. We recommend 3 months of folic acid, 5 milligrams, to protect your baby from risk of spina bifida. And so start that anyway, because conceiving does happen. So start it anyway the minute you're starting to think about planning for a pregnancy, or if you're having unprotected sex, because that's what happens.
That does happen. So we've talked about HbA1c and folic acid. Is there anything else that for pre-existing diabetes that women should know?
Not really. We do start aspirin, 150 milligrams once a day, but we generally wait till after you're pregnant. But if you are planning a pregnancy and you're on other drugs like angiotensin, ACE inhibitors, statins, then these are things that you're going to need to stop because they're not safe to use in pregnancy. So it's another thing to plan. If you have pre-existing diabetes, you may be on other medication, which is contraindicated. So see your GP and make sure that you're on safer alternatives if you need to be on them.
Yeah. So the key here is make sure you are, in contact with your GP and they are aware of your case and they're helping support you through that journey. Fantastic. So why do we need to do all of this then? What are the risks of diabetes to women in pregnancy and for the mum and for the baby?
Yeah. So if we're talking about pre-existing diabetes, the risks are different, really. So pre-existing diabetes, you have to think about that little embryo which is developing, and all the cells are dividing and multiplying continuously. Very complicated process. So we need those cells to be bathed in a very normal glucose medium. And if that medium is very high, then there's a risk of mistakes being made.
Okay, so sugar can cause, high sugar levels can cause these mistakes to be made during that developmental stage for the embryo.
And obviously that's critical because we do have a higher incidence of congenital malformations, more miscarriages, later in pregnancy, more stillbirths. And it's that very early period when that embryo is developing where we want perfection. We get imperfections in and out of diabetes, of course.
That's true. Yeah.
But if we're aiming for the gold standard there, then establishing really normal glycemic control, normal blood sugar levels at that point of conception and going forwards in the early stages, it's really key.
Amazing. I'm learning lots. I don't know about you ladies, but that is fantastic knowledge for me. Perfect. So essentially, it can be quite safe to get pregnant with pre-existing diabetes with the right precautions in place and the right planning. Okay, that's good. So ladies, go forth and procreate.
We still carry higher risks, but we call them higher risks, but they're not significantly higher. If we've got things as normal as can be right at the start, then it's very promising and no reason why you should hold back.
Yeah, so preconception care is really the key to successful outcomes. And
preconception care, early pregnancy care, absolutely vital. Which is why we see you as soon as possible. A diabetes specialist midwife will see you before your booking appointment, as early as you can, as soon as you know you're pregnant.
Wow. That's really efficient service, given we know the current state of the NHS. This is something that we need to get right. And, in a lot of the trusts up and down the country, there's a big move, along with part of this initiative called Saving Babies' Lives, to try and make sure that we provide the best care for women and subsequently, obviously, their babies. So that is why we focus a lot on preconception care, because if we get that right, then that sets you up for the best outcomes.
Yeah, for sure.
Okay, so we've covered a little bit about pre-existing diabetes, and now we're going to talk about gestational diabetes. So give us a little bit of a simple sentence on what is gestational diabetes.
Okay, So gestational diabetes is diabetes diagnosed within a pregnancy. So it's where there's a mismatch between the amount of insulin you can produce from your pancreas alongside your lifestyle habits, diet and exercise. So this may be because you've got a pancreas that doesn't produce a lot of insulin. It's just how it is. In pregnancy, your pancreas is expected to produce 3 times more insulin than it does outside of pregnancy.
Wow.
Or it might be that your pregnancy has made you very resistant. The hormones within the pregnancy, cortisol, growth hormone, human placental lactogen, are acting as barriers to helping that insulin work.
So can I just ask then, so we talked about insulin, which is made in the pancreas, is it? And so how, like, what does the insulin do specifically that means that, you know, that leads to this gestational diabetes?
So insulin is the only hormone that can take hold of glucose out in the bloodstream and unlock cells and put it into muscle cells or into fat cells. So without active insulin that's working, that the whole process is working, your blood sugar level will just continue to rise.
Oh, so it pulls the glucose, which is basically sugar,
Yes.
what we call sugar, out of the blood and parks it into the muscle and the fat. So this, and that you say this is the only hormone that can do that. So this hormone is obviously very important. And when it's working well, your blood sugar's in the normal range.
Yes, it works very hard to keep you in the normal range. And when your blood sugar's dropping, it just pulls back.
Okay.
You know, there's a feedback loop. So if you eat lots of sugar, it increases in a healthy person, and as the sugar's used up, the pancreas reduces the flow of insulin.
Okay.
So it's a complicated process, but it does work. And because it feeds skeletal cells, when you do exercise.
Yeah, so these big old muscles I've got here, my running thighs.
You need glucose for that.
Yeah.
And that the insulin is feeding into skeletal cells if you're very sedentary and couch bound. And that happens in pregnancy because you're exhausted.
Yes, hard work growing a baby.
Pelvic pain, all of those things. Then, of course, it's feeding it into fat cells. So this is part of why we like exercise in pregnancy, to sort of keep everything moving.
Perfect. That's really useful to know. Thank you. So it sounds like, you know, eating healthy can make a difference to your risk of diabetes in pregnancy.
Yes.
Yeah. How much benefit is there to eating healthy?
Extraordinary benefit.
Okay.
I mean, diet is all about diet, really, and our whole lifestyle. So unfortunately, every culture, it's all about feeding, isn't it? You feed people if they're sad, you feed people if they're happy, you feed people to be part of community, you yourself eat when you're sad or you eat when you're happy. It's very complicated. It's very part of our cultural processes. And so eating healthy is tricky, because my worst nightmare is going into a garage service forecourt. It's brilliantly done. It's lit. It's shiny. It's attractive. It's fast food. It's highly processed.
Yeah.
It's bad for your gut microbiome. It's bad for every part of your body, really. It's a highly processed food. So we have to rethink the way we eat. And we're looking for low glycemic foods that don't spike your blood sugars up high, and clean cooking. So you're making your own foods from natural ingredients. You know where they come from, you know what they're doing. And all of those things are going to protect us, not just from diabetes, but from other health disorders as well. It's hard work, starting a meal from scratch and peeling the potatoes and chopping up the onions. You know, it is hard work. And when you're exhausted and tired, it's not very appealing.
Yeah.
But this is the way we've got to go.
I guess when we're talking about healthy eating and how challenging it can be to eat healthy, what are good foods to eat and what are the main things to avoid? I know that's probably quite a long list, but just give us a few examples.
Yes, I mean, it's, you know, look at healthy eating websites for advice, but, you know, we're looking for healthy fats, so things like olive oil, vegetable oils, avocados, nut oils, all of that, so healthy oils and fats. we're looking for less processed food, so whole grain food, whole grain bread, granary bread, seeded bread. Pasta is fine, just eat it in moderation, you know, and maybe go for the whole wheat varieties. Rice is also fine in moderation, but go for the less processed rice. So look for basmati, wild rice, whole grain rice, and avoid things like the easy cook rices because they've already been processed along. And there is, interestingly, research behind reheating foods like pasta and rice.
Yeah.
You have to take a great deal of care with rice, particularly because of microorganisms. But it changes the chain. So we're looking for complex carbohydrates. And reheating pasta, it has a lower glycemic index than ready cooked pasta. So those things are good for you, you know, but just manage portion size and maybe don't have it for breakfast, lunch and dinner. It's modifying those sort of practices. I would always avoid sticky rice. It's full of sugar, you know, to make it sticky. I guess they've done those sort of things like that. All vegetables are fine. I mean, moderate your potatoes, have jacket potatoes, eat new potatoes with their skins on. This sort of thing to increase the fibre in your diet is very important. Fruit is fine. Again, modify it, maybe not 5 oranges all at once. But that is an interesting point, actually. Fruit juice is never good for you. It's not good for anyone in or out of diabetes.
Oh, wow.
It's rocket fuel. We use it for bringing people back with severe hypoglycemia.
Oh, wow.
Do not have orange juice or apple juice or fresh fruit juice. Eat the orange, eat the apple.
Get the fibre, get the nutrients.
Don't have an innocent smoothie. There is nothing innocent about it, if I'm allowed to say that. You know, these things, and don't give it to your children because, again, it's a very high glycemic, fast-acting glucose.
Oh, wow. Okay, that's good to know. Yeah, and I think that's really important as well, especially if you're from like the global majority. Like I'm Nigerian, so we love rice in various forms: jollof rice, fried rice, like we ground rice. We even sort of make it into a paste, and yeah, there's lots of ways that we love rice. But I have seen some really great recipes, and there's a document that's been made by Lewisham Hospital which sort of focuses on ethnic foods, and it's got sort of different variations of how to make some of those common dishes, some Caribbean foods, some Indian and Asian foods, and some African foods as well. They've got some modifications on those recipes so that you can continue to enjoy, because we're not saying cut it all good tasting things out. We're just saying modify it so that we can give you the best chance of having a healthy pregnancy with the best outcomes as well. So definitely look online. There's lots of good resources out there. NHS Choices will have some options as well on alternatives and ways that you can manage your diet. And it's just little changes. That's what we little changes are better than no changes at all, or one big change that you then sort of slip back into old ways. It's much easier to have little progressions than to try and aim for big steps at a time. Yeah. What about weight management? How there's a lot out there at the moment.
There's a lot of exciting stuff going on out there at the moment, and we are excited about that and delighted actually that these weight loss drugs are more available now.
Yeah.
And they're as far as we know, safe to use. We've used them in type 2 diabetes for a long time.
Yeah. So they're new, but not so new.
They're not unknown.
They're not unknown, yeah.
And as the women I see using them, it's working very well. I mean, that's the ones I'm seeing, not the ones I'm not seeing, obviously. But yes, I'm very happy about that. But you have to stop them the minute you've conceived. They're not safe in pregnancy. Getting down to a healthy weight is really important. Will protect you from diabetes and improve diabetes, may even put you into remission if you have type 2. It'll prevent you from getting gestational diabetes if you've managed to reach an optimum weight before conceiving. So we are delighted, but we can't use them in pregnancy or when we're breastfeeding.
And so then I guess women might be quite concerned about what to do if they don't want to rebound, get heavier again. They don't want to have those sort of adverse effects that they were having prior to taking these medications. So how can we support them? What can we do to help women?
Yes, that's tricky. We haven't really got there yet. So at the moment, we're stopping the GLP-1s the moment somebody knows they're pregnant. And interestingly, I'm seeing more and more women, because you are more fertile. Once you have dropped that weight and your BMI has come down, you're ovulating much better, your metabolism is much healthier. So I am seeing lots of women, and we're taking you off them in pregnancy, and we're hoping you can stick to a healthy diet and exercise during that time. And after the baby and after you finish feeding, you have the option to go back onto them if it's still appropriate at that time. And they are talking about using very low dose stabilizing doses to keep your appetite low long term. So I think it's very positive for the future.
That's great. So I think from what I'm hearing you saying, it's about the balance of not just the weight loss medication, but also that diet, that exercise, that healthy lifestyle. Putting all of those things together and maintaining those habits will help, even if you have to sort of come off of your weight loss injections. Bear that in mind, that although we don't sort of we advise against them in pregnancy, we can definitely support you with ensuring you have the right sort of diet, exercise and lifestyle. We do have sort of healthy lifestyle midwives. We have other ways of supporting you through dietitians as well in pregnancy. So if you felt that actually it would be a challenge for you because if you've been using that for quite a while and it's given you the outcomes and the results that you wanted when you got into it, then it might be quite daunting to think that you need to stop them. So that's what we're here for as a team. Well, Rachel and her team, and also me in the background.
It's a very motivational time, pregnancy. So it's you've got someone else's interests at heart as well as your own. So hopefully we can keep you going through that.
Yeah. So, just to wrap us up then, what are some common misconceptions that you've come across in your many, many years of practice as a specialist midwife in diabetes?
They vary a lot. I think eating for two has been a long-term misconception. The baby is really tiny to begin with. It doesn't need very much at all. And then as it grows, that requirement will increase, obviously, but you're still not eating for two people, two big people.
I had the appetite of two, though, I have to say, at first. Or maybe that was just my excuse.
Yes, you do. Yes, it can happen, but don't eat for two. Eat for one and a little bit, and that'll be fine. I also have women asking me if their baby will have diabetes. Now, we do check routinely a baby's blood sugar when it's born at about 3 hours and about after 6 hours if you've been affected by diabetes in the pregnancy. Now, the reason for this is not to check that the baby has diabetes, but one of the consequences of raised blood sugar levels as a pregnancy continues is from after 12-14 weeks, the baby in your womb is actually producing its own insulin from its own pancreas to modify its own blood sugar.
So early? That early?
So early.
Wow.
So if your blood sugar is high, then that baby is receiving that sugar, is responding by producing more insulin from its own pancreas. We call it hyperinsulinemic. And the baby, in the same way as you, is having to lay down the extra sugar into fat cells because it doesn't have skeletal cells, it's not exercising. And consequently, that baby is growing bigger than it should, and it's accelerating the growth because insulin is also a growth hormone. So long-term raised blood sugars will produce a bigger baby who's laid down not only visceral fat around its organs, but subcutaneous fat under the skin.
Okay.
And this means this baby is not as healthy as it should be. Where am I going with this, Daddy? I'm trying to remember.
Is that baby then at risk of... So we know that's why diabetic women have a higher chance of having a bigger baby. But also, does that increase their risk of diabetes then?
Yes, that's where we... Yes, it does. Because if you consider that baby's pancreas is already working extra hard, it's already wearing out its pancreas.
Yeah.
So in that way, it's compounding a risk for diabetes in later life.
Yeah.
So whilst we don't expect that baby to have diabetes, it won't have diabetes, it's actually compounding a risk for that child, for that young person, that adult in later life. And of course, we're very ambitious and we want to kind of prevent that happening. In the same way, the baby will have the signs and symptoms of someone with diabetes. So someone who has a very concentrated blood sugar level is weeing more and drinking more. So we're looking for polyhydramnios around that baby, so extra fluid around the baby in the womb. And we also have concerns now that we're switching on genes for diabetes.
Okay.
So we used to think that you either had a gene or you didn't have a gene, but now we understand there are mechanisms for switching on genes. So raising that baby's blood sugar levels in utero, in the womb, while it's still growing, causing the baby to make more insulin, is actually increasing the risk for that child in later life. So very important to keep those sugars normal during the pregnancy. But going back to where I was saying when we're testing the baby, so when we're testing the baby after birth, we're looking for hypoglycemia, low blood sugars. And the reason for this is because that baby could have been producing more insulin for itself throughout its journey in the womb. When it's born, its pancreas runs on doing that.
But it's no longer attached to the cord, which is bringing that high sugar environment. No longer receiving the extra sugar.
Okay. And the consequent risk is it can go low. And low blood sugars are very dangerous for babies.
Yeah.
You know, it's a very dangerous thing to have a low blood sugar in a baby. So we will be checking at least twice. And if your baby has low blood sugars, and that can happen in and out of diabetes.
Yeah, that's right. Yeah.
Lots of other reasons for low blood sugars as well.
Yeah.
And treating that baby accordingly with sugar, effectively.
Yeah. And we try and get them feeding as much as possible. So we go for the colostrum because that's jam-packed full of calories and nutrients and, that natural sugar that homemade for baby. And if that baby still needs a little bit more support, then we go straight for the sugar gel, don't we?
Yes,
the glucose gel and to pop that in their cheek. And
which is great now because in the old days we had to use cow's formula. So we were introducing artificial formula to treat it. But now, thank goodness, we're now using glucogel, just a pure little glucose shot.
Yeah, a little shot for baby. Usually does the trick as well. And then we just try and establish that feeding, support mum, however she's choosing to feed, to make sure that we can keep that blood sugar as stable as possible through maternal milk. Perfect.
Okay.
So this has really been great. I think what I just wanted to round off with as well is that women in pregnancy, we offer them, how do we test them for diabetes?
Oh, good question. So at your booking appointment, the booking midwife does a screen for diabetes. So she'll ask you questions about risk factors that are higher incidences of diabetes. So ethnic origin, BMI, previous big baby, glucose in your urine, a range of those things, and that will trigger her to either offer you a glucose tolerance test at around 16 weeks or at 28 weeks. The majority of women we see at 28 weeks because that's the time when you're really pregnant. Those pregnancy hormones are raging, and that's the time when we'll pick up the most people who have got insulin resistance. So it will usually be then. If you've had gestational diabetes in a previous pregnancy, we'll also look at you at 16 weeks.
Yeah. And that's for the most part of that will be having the glucose tolerance test, which is this very sugary drink. I remember having it, not fun. So yeah, you have this sugary drink, don't you? So we take your blood before you have the sugary drink. We then, that gives us a baseline of your blood sugar. Then we give you the sugary drink and we retest your blood 2 hours later.
Yeah, see how you've metabolized it. If your pancreas has been able to produce enough insulin to deal with that peak in your blood sugar rise and put that glucose away.
Yeah. And so if it's normal, then that reassures us that, at that time your body's coping well and you don't have gestational diabetes. It doesn't mean you won't get gestational diabetes. For the most part, women are fine and they don't go on to develop gestational diabetes, but we do have women come back a bit later, 32, 34 weeks.
We do.
And they show us signs, for example, like glucose in their urine, or they've had a measurement of their tummy and it's showing that the baby is bigger than anticipated, and we confirm that with a growth scan and it tells us, oh, baby's tummy is quite quite big, and the estimated weight of baby is quite big. Obviously there's a margin of error with the scans, but that might then prompt us to recheck that glucose test again, and which might then tell us, oh, actually yes, there is gestational diabetes that's developed, and then we can manage that as appropriate. And then common management, how do we?
Well, we've got a few tools in our box. So we start with diet and exercise.
Yeah.
Then and we give you kits to test your blood sugar 4 times a day, so you know
finger pricks, isn't it?
Exactly what's happening every time you eat something. And then we would offer metformin, which is a very, very commonly used oral hypoglycemic. It lowers your blood sugar by improving your tolerance to insulin and reducing the amount of sugar that's absorbed from your food. And then we will try that. And if that doesn't work or it's not acceptable to women, then we will start insulin. And we love insulin. It's a very pure tool. It goes into your bloodstream, it removes glucose, and it's very easy to use.
So it's sort of a step up. We monitor and we stage and we see, well, it has diet, modifying your diet, has that worked? If not, then we go to the metformin, and the metformin, that's a tablet that we give you to take in varying doses, depending on how controlled or not controlled your blood sugars are. It does have some side effects. What are the common side effects of metformin?
Very upset tummy. Actually, but it usually settles after a couple of days.
Yeah, so persevere. If you're on it, just give it a few more days and see how you get on. And that works quite effectively for most people. And then there's some people who will need to move on to the insulin, and that is an subcutaneous injection.
Yes, little injection with a disposable pen.
Yeah,
very painless, actually. Very easy to use, and women are very reluctant to use any medication in pregnancy. But I try and put it in a very different light, because actually this is pancreas saving medication. This is giving you insulin or metformin so that your pancreas can work better, and that it doesn't have to work so hard, so it will last longer. Because one of the problems about gestational diabetes is it increases your risk of type 2 diabetes in later life. So anything we can do to be kind to your pancreas, to nurse it along so that it lasts longer, is a good thing in my view.
Yeah. And that is a great point that you've touched on there, is the risk in later life. So with gestational diabetes, does it always resolve after baby is born?
Ooh, usually.
Usually,
now,
for the most part.
Sometimes we find that women have actually converted to type 2 diabetes in the pregnancy.
Okay.
When the pregnancy ends, it doesn't go away. So that is type 2 diabetes. And we'll manage that via your GP with diet and exercise, possibly metformin, maybe GLP-1s if you have a raised BMI. So there is hope there anyway. But otherwise it does go away. As soon as that placenta's birthed, all of those hormone levels drop. All of those pregnancy hormones are gone. So just like that, your insulin sensitivity has returned. Yeah, so the risk of gestational diabetes long term is that 50% of women with gestational diabetes will go on to get type 2 diabetes in 5 years.
Wow.
With the fastest conversion rate being in the first 2 years.
Wow.
So to be one of the women who don't get it, please stick to the diet, stick
Yeah.
to the exercise, and you're likely to be protected by that.
Yeah.
And you can use the GLP-1s.
It's like
If
your
you have a
Manjaro type
raised
medication.
BMI.
Yeah, Manjaro and I don't know other
Yes,
brands,
if you need
but
a
I think
weight loss.
people know commonly the brand name, sort of Manjaro and that, don't
Yeah.
they? Perfect. So yeah, so there are options, and it's, you know, if it's not the be all and end all, if you do develop gestational diabetes, it's a good hint about the things that you need to do
Yes.
to protect yourself in the future. So although it may be quite daunting, we are very good at supporting women through pregnancy with gestational diabetes, with pre-existing diabetes. But, you know, it does sort of put you on the radar to make sure that we are taking the precautions for the best long-term outcomes for you, because you'll have your family that, you know, that will need you. So we want you to have a long and healthy life.
We want you to see your great grandchildren.
Oh yes.
And it's so common now. I mean, we're talking about 15 to 20% of pregnancies.
Wow.
So you are not alone, and it's not that unusual now.
Yeah.
It's the way our society is taking us. It's not just you.
Yeah. Perfect. So where can women go to get more advice or support? I think so. We talked about GP. Are there any sort of national initiatives or programs where women can get information and advice from?
Well, there is the National Diabetes Prevention Programme.
Okay.
Which you can self-refer if you get a raised HbA1c. Once you've had gestational diabetes, you can self-refer into that anyway.
Okay.
And it's a very motivational course to try and help you, because preventing this condition is so much better than treating it. Otherwise, I would look on healthy eating websites, weight loss websites.
Yeah.
I don't think we can recommend private websites on here, but if you type it in, you'll find them. They'll just come pinging up.
I'm sure they will
for you.
But yeah, with any condition in pregnancy or pre-existing conditions, knowledge is power. So make sure you are out there educating yourselves, and yeah, seek support and advice where necessary. A lot of NHS hospitals and maternity services up and down the UK will have information and that's accessible to all women in various languages as well. So definitely be proactive, and yeah, I think that,
go for it.
Go and make those babies. So keep us in a job. Wow, thank you so much, Rachel. That's been so informative, even for me. So yeah, 12 years later, I'm still learning. So it's always great to hear from the experts out there. Thank you so much for joining us.
Thank you very much for having me, Dede.
Yeah, like, subscribe, and yeah, wait to see more episodes.